participants are joining.
Ready?
Yeah, just participants are joining. MashaAllah, we reached 800 by now. I think we're good. We can probably start. Assalamu alaikum. Good evening, everyone. It's a real pleasure having you tonight, talking about a very important and crucial topic, which touches very well on our local needs and importance. As you all know, diabetes is a real issue in Saudi Arabia and in the region. And following that, cardiovascular diseases that affect our diabetic patients. So it is, with no doubt, an important topic to be discussed again and again, and being touched on the important updates and management strategies for such patients to reduce the risk. And I'm delighted to be joined today by senior interventional cardiologist, a dear colleague, Tasmia Lawand, who has extensive experience in managing such patients. If you may allow me, I'm going to start with a short introduction before I give the floor to Dr. Samir to give us the management strategies for such patients. So the topic today is the residual cardiovascular risk in type 2 diabetic patients, what lies beneath. As I said, I'll be with you, Walid al-Qarib and Dr. Samir Lawand tonight. Now, cardiovascular disease is the most common cause of death in people with type 2 diabetes. It's probably the most common death in Saudi Arabia in general, but in Saudi Arabia has one of the highest rates of diabetes in the world. And many registries have shown that the incidence or prevalence ranges between 51 to 72% in patients with established cardiovascular disease. And we also have one of the highest rates of age standardized cardiovascular disease mortality in the GCC region, estimated between 329 to 379 per 100,000 people. What do we mean by residual renal cardiovascular risk in type 2 diabetes? It refers to the remaining risk of cardiovascular events and diabetic kidney disease even after achieving the optimal glycemic control. As we all know, in diabetes, we went for a long time after blood sugar control, which is important, no doubt, but nevertheless, even after the optimal control, we still have remaining cardiovascular risk. Just understates the role of diabetes in general as being a vascular disease. It's probably just a vascular and cardiovascular disease by itself, not just blood sugar adjustment. So there's a 91% residual risk of MACE, post-glycemic control, about 80% residual risk of diabetic kidney disease, and a 100% residual risk for heart failure in patients with diabetes, even after optimal diabetes blood sugar control. The residual cardiorenal risk in these patients has been reduced significantly, but still remains in patients who have been on the treatments that we are familiar with, whether it's in the intensive glucose trials. The MACE remains, as I said, 91%, kidney disease 80%, and heart failure 1%. And of course, it differs according to the modality of treatment. So those who are indeed before inhibitors are like being on nothing when it comes to residual risk, whether it's MACE, kidney outcomes, or heart failure, 100% risk residual in these patients. Now, SGLT2 inhibitors reduces that risk by 12% for MACE, 39% for kidney outcomes, and 33% for heart failure. GLP-1 receptor agonist as well reduces the MACE risk by 15%, the kidney outcomes by 17%, and heart failure by 9%. So as you can see, the actual modality of treatment or type of treatment affects that risk. Now, looking at these treatments, we know that GLP-1 receptor agonists have proven to reduce the risk of cardiovascular events and associated with improvements in weight loss and glycemic control. SGLT2 inhibitors show significant benefits in reducing the progression of heart failure and kidney disease. Lower rates of major cardiovascular events have been observed in these trials. So it makes sense that the combination of these two treatments, GLP-1 receptor and SGLT2 inhibitors, can enhance overall patient outcomes by addressing residual risks effectively, whether it's the cardiovascular risk, heart failure, or kidney diabetic kidney disease. And we have stated that very well in the Saudi Heart Association statement on cardiovascular disease and diabetes mellitus, that GLT2 inhibitors and GLP-1 receptor agonists are two major glucose-lowering drug classes associated with benefits in terms of cardiovascular risk reduction. Other therapies, DPP-4 inhibitors, sulfonylureas, insulin and metformin, have no demonstrable effect on cardiovascular risk. While glitazones are associated with adverse outcomes, some glitazones, as you know, have been shown to increase the risk of heart failure in diabetic population. And this has been addressed very well in all the treatment guidelines, and touching on the evolution of the recommendations in major guidelines over the years. As you know, the target was the glycemic approach, controlling blood sugar, and over the years, because of the risk of hypoglycemia with many drugs, we were able to achieve the actual targets, but with newer medications and less hypoglycemia, we are. But nevertheless, having cardiovascular outcomes, overall outcomes, is the target beyond glycemic control. And this is what we have been able to achieve with the use of the SGLT2 inhibitors and GLP-1 receptor agonists. And the guidelines have stated that very well. As we all know, both the OCC and the European guidelines, depending on your baseline risk of patients, if atherosclerotic cardiovascular disease or high indicators of cardiovascular disease were available, the GLP-1 receptor agonist with proven cardiovascular benefits or SGLT2 with proven cardiovascular benefits were the first line therapies. And if it's still uncontrolled, you should consider combining both of them. If it's heart failure, or mostly heart failure, risk in these patients with SGLT2 inhibitors are the first proven. If chronic kidney disease is the risk, and they are on maximum treatment for prevention, SGLT2 inhibitors followed by GLP-1 receptor agonists, and in those with uncontrolled, the combination of both is the best therapy. If your goal achievement is to maintain weight loss with glycemic goals, as we all know, that the GLP-1 agonists, as well as GLP-1 GLP, semaglutide or tirzepatide, have the highest efficacy in such patients and should be the target therapy. This is just to touch on the importance of having the base of the risk for patients deciding which therapy you're going to go for. And as mentioned in many of the guidelines, whether it's the European Society of Cardiology in 2024, patients with diabetes and atherosclerotic cardiovascular disease, GLP-1 receptor agonists or SGLT2 inhibitors with proven cardiovascular benefits are recommended to reduce cardiovascular risk. The ACC have added patients with prefers to disease and type 2 diabetes, GLP-1 receptor SGLT2 inhibitors are effective to reduce risk of MACE. So again, having medications with proven cardiovascular benefit is our target. Very importantly, now the role and the importance of metabolic disorders in general. The cardiometabolic risk is a very important target that we should look at. Obesity, unfortunately, is understated. Not many people realize that obesity is a disease by itself, and it affects many areas, whether it affects your heart, your kidney, your liver, and it increases the risk of diabetes as well. So it should be a multi organ approach as well. You should have the management should address all parts, whether lifestyle, medications, medications to manage the comorbidities as well. I mean, it is not a specific disease management. Weight loss is a target, but the complications of the weight loss are also addressed. It's very important to address all these parts. The European Society of Cardiology, for example, has mentioned or has taken this into consideration in a more personalized approach. So you look at your patient and the patient's needs, and it actually staged the management of metabolic disorders and sequely the European Atherosclerosis Society consensus statement addressed the importance of course, treatment with diabetes, your MASH and fibrosis, the cardiovascular hepatometabolic disease right now is becoming a new trend and new interest because of what it leads to from worse and cardiovascular outcomes, including leading to heart failure, whether it preserves ejection fraction, which is most likely, or reduces ejection fraction. MASH can even lead to cirrhosis, the infection of cardiovascular disease, and clinical manifestation of atherosclerotic cardiovascular disease. Targeted therapy for each one of them is important. Now, you will hear this more in the next lecture, but I would not be exaggerating when I say that GLP-1 agonists actually target many aspects of these stages of cardiometabolic disease, whether it improves your risk of heart failure, your kidney disease, your cardiovascular disease, and even MASH. So it's very important to decide which medications you use. And these are examples of GLP-1 receptor agonists and GLP-1 GIP receptors with different doses. So I hope I gave an overview about the importance of the residual risk and the target that we need to be looking on. And it is my pleasure now to invite Dr. Samir Lawand to touch on the clinical use of GLP-1 and SGLT2 receptor agonist synergistic use from evidence to practice. So please, Dr. Lawand.
Okay, thank you, Professor Walid. With this introduction, you really highlighted the importance of the what you called of targeting the cardiovascular and renovascular outcomes of patients with diabetes. I need to share. Okay. All right. Okay, so this represents yet the practical aspect of what Professor Walid have talked about how we can make use of the best available pharmacological agents that would help prevent cardiovascular and renovascular outcomes in patients with diabetes. As you know, there are pharmacological effects that we need to address because diabetes is so devastating, and we need a medication like a GLP-1 receptor agonists with multifactorial effects to help us in tackling issues related to diabetes outcome. You will see here, for example, all aspects and all components of our systems are likely to be affected by diabetes. Meanwhile, our drugs like GLP-1 receptor agonists can affect each and every one of them, like the GI tract, where gastric emptying can be slowed down, the pancreas, where alpha cell glucagon secretion will be enhanced, as well as beta cell functionality improved with insulin biosynthesis. In the liver, reduction of hepatic steatosis or glucose production, insulin sensitivity, and de novo lipogenesis. Of course, the heart is another target organ where inflammation, oxidative stress, and renal angiotensin axis is also improved and reduced. With the kidneys, natriuresis, diuresis, inflammation, oxidative stress, and renal angiotensin axis is all improved. With the brain, body weight related, what you call satiety related, food intake related, all of this, along with insulin sensitivity in muscles and lipotoxicity reduction in adipose tissues. If we look at the SGLT2 inhibitors, you will see it has similar or perhaps more hemodynamic effects, like a decrease in the ratio of insulin to glucagon, leading to increasing ketone bodies. But this is not clinically important except when patients are critically ill. A reduction in HbA1c of up to 2.7%, which is remarkably good. And also, of course, compared to or combined with other hypoglycemic agents, improve cardiac energy, metabolism, pathology remodeling, improving oxygenation, hemoglobin hematocrit, promoting diuresis, natriuresis towards the kidney, reducing to a relative extent blood pressure, improving cardiac load, unloading the heart in a way, suppressing tubular hypertrophy, and regulate tubuloglomerular feedback. Of course, the anti-inflammatory effect cannot be ignored, with the reduction in oxidative stress, apoptosis, and increasing circulating pro-angiogenic progenitor cells. And reductions of weight, this is complementary, however, is not as noted with GLP-1 receptor agonists. Now, together, the GLP-1 receptor agonists, as opposed to SGLT2 inhibitors, you will see GLP-1 has similarly inflammation and less tendency for ischemic injury, increased glucose uptake, increased heart rate and LV function, endothelial function, vasodilatation, blood flow, and of course, reduction in total lipid accumulating patterns and platelet aggregation. Of course, with this together, the reduction in vascular inflammation and smooth muscle proliferation. With the SGLT2, as I said, it's more like hemodynamic effect, with the reduction in blood pressure, sympathetic tone, endothelial function improvement, vasodilation, improving RAS activity, reduction in inflammation, oxidative damage, erythropoiesis, and hematocrit. Of course, reduction in hypertrophy, preload, afterload. All of this will contribute to reduction in fibrosis, arrhythmia, demand, carbon dioxide demands, etc. Now, the GLP-1 receptor agonist anti-atherogenic effect is predominantly targeting what we call atherosclerotic cardiovascular-related effects. You will see offering cardioprotection via anti-atherogenic effects, atherosclerotic disease reduction, and seem to have a consistent benefit in atherosclerotic components of MACE. SGLT2 reduces cardiovascular risk via hemodynamic effect and changes in energy metabolism, of course, reduction in heart failure and or reduction in progression to advanced CKD. For that, you will see that SGLT2 is also important as a first choice where heart failure or CKD predominates. Overlapping properties will help us decide that co-administration will improve comorbid conditions. For that, most people with diabetes and cardiovascular disease could take advantage of the complementary effects of the two drug categories. For that, there is also greater evidence supporting the anti-inflammatory effects of GLP-1 receptor agonists versus SGLT2 inhibitors. Now, beneficial effects of SGLT2 has been shown by different studies, including empagliflozin, canagliflozin, DAPA, and ertugliflozin. And you will see the effect in different aspects of MACE, practically the same, although it may differ a little bit, where empagliflozin have more all-cause death effect than the others. Similarly, Gamvas with canagliflozin has more MACE effect, as well as DAPA, where heart failure hospitalization is more prominent and more importantly showing advanced benefits similar to that of ertugliflozin. Long-acting GLP. Now, GLP-1 receptor agonists, both injectable and oral formulations, have shown to reduce MACE. And with that, you will see that the studies on LEADER and SUSTAIN have shown reductions in the 3-point MACE, as I indicated earlier, and also FLOW and SOUL for GLP-1 RA benefits for these patients, where all in all, the number needed to treat based on these studies is about 63, which is anywhere from 48 to 97 patients to reduce an event, which is a reasonable number. Now, in this meta-analysis of all studies related to cardiovascular outcome benefits from GLP-1 RA, this has been shown to be measurable, with measurable significant reduction, anywhere from MACE to cardiovascular death to all-cause mortality, fatal, non-fatal MI, fatal or non-fatal stroke, heart failure hospitalization, and a composite endpoint with renovascular improvement, which is also quite obvious and more importantly shown. Now, if you look at the so-called lowering effects shown by the anti-diabetic drugs and their cardiovascular benefits in these trials discussing cardiovascular outcome results in diabetics from 2015 to 2024, you will see that all different drugs has been studied intensively, anywhere from the light blue GLT2 inhibitors to the GLP receptor agonists in dark blue to the combination in tirzepatide to DPP in light green, and of course basal insulin. And basically over the years from 2015 to 2024, the studies basically on SGLT2, GLP-1 RA has shown remarkable impact on outcome, whether it's oral or for the semaglutide or once weekly injections. For the years 2021 to 2028, the studies including SGLT2 and 1 SGLT2 alone in light blue, GLP-1 in dark blue, and GLP-1 GIP combination in SURPASS, which is a study yet to be reported, will be later in this year, Q4, tirzepatide. Then you can tell that previous and ongoing trials, with or without results yet, are all showing in that direction. Sustain 6, which is a once weekly semaglutide injectable treatment given has shown reduction in MACE, which is remarkably shown over the follow-up of more than 2 years, indicative not only non-inferiority with a significant P, but also significant for superiority over the placebo, with related to first occurrence of cardiovascular death, non-fatal MI, or non-fatal stroke. And the number needed to treat in order to reduce an event, which is particularly important related to cardiovascular death, non-fatal MI, or non-fatal stroke, is 45 patients for 2 years. Let's look into SOUL trial. SOUL trial is actually a study on oral semaglutide individuals with diabetes with established atherosclerotic cardiovascular disease and or chronic kidney disease. They included the patients were, of course, randomized, blinded for controlled cardiovascular outcome, comparing the oral semaglutide with the placebo, of course, other standard of care treatments. And they selected patients who were diabetics with HbA1c of more than 6.5%, and had CAD, cerebrovascular disease, symptomatic PAD, peripheral artery disease, and CKD. And they initially randomized the patients to 3, then 7, then 14 milligram once daily over a period of weeks, 3 to 4 to 8, and then followed them up about 5 weeks, and then further follow up. And they looked at the they included criteria like, of course, males, females, diagnosed diabetes, as I said, HbA1c, coronary disease, cerebrovascular disease, symptomatic peripheral and or chronic kidney disease. They excluded patients with myocardial infarctions, strokes, or hospitalization for unstable angina within the last 2 months, planned carotid or coronary revascularization, or even peripheral treatment with GLP-1 before, and classified with New York Heart classification as class 4 heart failure. Primary and confirmatory secondary outcomes were also followed. The primary included cardiovascular death, non-fatal MI, non-fatal stroke, and the confirmatory secondary outcomes were also important. This included 5-point major kidney disease outcome benefits, including cardiovascular, kidney-related death, onset of more than 50% reduction of eGFR, onset of persistent eGFR reduction to less than 15, initiation of chronic kidney replacement therapy, cardiovascular death, and development of first major adverse limb events, including acute limb ischemia or chronic limb ischemic hospitalization needs. And if you look at the baseline characteristics of these 9,500 patients included in the study, you will see the females were mostly let's say 2/3, 1/3 males, mean age 66, Asian, black, whites represented 2/3 of the patients. Participant by cardiovascular inclusion, 70% with CAD, 42% with CKD, and 21 to 15% with stroke and peripheral arterial disease. Other of the participants included clinical characteristics, included mean HbA1c of 8%, mean BMI of 33, quite overweight, eGFR mean 73, and type 2 duration more than 14 years. Of course, those who included in this trial, 26% were receiving also SGLT2 at the same time. Now, oral semaglutide in this trial have shown the reduction in the risk of MACE by about 14% relative to placebo in type 2 diabetic with atherosclerotic and or CKD, including the primary cardiovascular outcome that I mentioned earlier. And over the period of follow-up of 54 months, you will see that there is an important significance in reduction in this, what you call MACE reduction. Each component of the primary outcome contributed to the superiority risk reduction. The summary of supportive secondary outcomes included MACE by 16%, non-fatal MI 26%, coronary vasculitis 25%, of course, HbA1c reduction, body weight, and HSCRP, pro-inflammatory risk promoter. Oral semaglutide thus reduced 3-point MACE similar to that of EMPA and CANVA, fliflozins. In these two trials, there was some GLP added, and in the SOUL trial, where oral semaglutide shown the 3-point MACE, of them, 26%, 27% actually had SGLT2, yet it continued to show the added benefit. The safety profile of oral semaglutide in SOUL was similar to the other trials, whether it's serious adverse events or infections, infestations, cardiac cirrhosis, although usually the difference is driven by that, but this is more important perhaps to SGLT2. Adverse events leading to permanent treatment discontinuations, and this was common more with the semaglutide, which is slightly different, and of course the reasons for discontinuation due to gastrointestinal disorders. Now, look at the functional outcomes in patients with peripheral arterial disease and type 2 diabetes. And this has been addressed by STRIDE trial designed to have 790 plus patients, including those with HbA1c less than 10, peripheral arterial disease, intermittent claudication, pain-free walking more than 200 on a flat treadmill test, or walking distance of less than 600 on a constant load treadmill test. The trial included the objective of delivering once weekly subcutaneous semaglutide on functional capacity, and randomized phase 3 double-blind group in parallel, and they looked at the primary outcome over the period of 52 weeks. And they noticed that the primary endpoint of once weekly injectable semaglutide 1 milligram increased maximum walking distance by 13% in those with diabetes and peripheral artery disease versus placebo on top of standard of care, median improvement 26 meters and mean improvement of 40 meters. Now, strong cardiovascular benefit to different metabolic populations as well. And this included the studies as of 2017 on the way to 2025. Some of them were completed, like in the DASH, but not published, as in the dashed compartment, completed and published in the red continuous line in SELECT, SOUL, FLOW, and ongoing trial like REMODEL. All of these address the role of semaglutide, whether it is once weekly injectable, oral, and of course, functional and cardiovascular outcome benefits. Now, let's look at my experience with my patients. This is a patient who's 50-year-old male with established coronary artery disease, previous interventions, who came to me first time in 2022, diabetic, hypertensive, dyslipidemic, and obese, weight 111 kilos, height 179, BMI 34, BP was okay, and HbA1c at that time was only 6.4, prior to which it was 6.2, and you will see that his lipid profile acceptable at that time, treated with anti-lipids as needed for his ischemic heart disease, and a microalbuminuria of 9, which is considered acceptable. Now, the medications included Concor, Pantozole, Glucovance, Ivarine for seizure, Januvia, Plavix, and Exforge for his blood pressure. Now, at that time, the patient was considered stable and basically was for renewal of medications, but treatment plan included follow-up laboratory, plan for lifestyle changes, continuing treatment, and initiating for weight reduction and better HbA1c control, which is slightly on the rise, using the triple escalating therapies, 3 milligram, 7 milligram, 14 milligram on a monthly titration. Let's go back to SOL, where oral semaglutide, as I told you earlier, has shown benefit in reducing MACE by 14%, and this should be applicable, which of course includes cardiovascular disease and or CKD, should be applicable to our patients over the period of 54 months of follow-up. Again, the change in HbA1c is expected. The BMI weight reduction is expected to be 4 times more than without. And of course, HSCRP reduction is quite observable. And 1 year later, the patient has shown significant improvement in his cardiometabolic profile. HbA1c dropped from 6.4 to 5.2, weight from 111 to 99. Total cholesterol continued to drop down to 2.77, triglycerides from 2.4 down to 1.8 and 1.4, and of course these continued to be there throughout the follow-up. Now, so what happened is that patient HbA1c and weight improvement over the period of follow-up, and the only difference was the addition of Rybelsus 14. Case number 2. A 57-year-old female who was seen first in November 2022. Diagnosis was atrial fibrillation, recent TIA, very high stroke risk at that time considered, including hypertension, DLP, dyslipidemia, diabetes, and obesity. Now, at that time, this weight is wrong, actually. Her weight was 86 kilos. Height 148 compared to her height is remarkably high. BMI 30 and blood pressure, etc. Okay, HbA1c at that time 9%, LDL high, total cholesterol quite high, triglycerides very high, AST, albuminuria 24, also slightly high. Now, medication included Concor, Sevitens, Apixaban, Zigdo, combination DAPA and metformin, and A to Z, which is a combination of Atorva plus ezetimibe. Now, basically, this patient was an uncontrolled diabetic, uncontrolled hyperlipidemic, and obese. For that, the treatment plan was to first, of course, emphasize the importance of lifestyle changes, managing patients at higher dose of A to Z, 1040 instead of 1020, initiate Ozempic, titrate from 0.5 to 0.5 to 1 on a once weekly basis. Now, the goal was cardiovascular kidney risk reduction in high-risk individuals with type 2 DM, which applies to my patient. And basically, in patients who have these combinations, for these individuals, addition of GLP-1RA, consider addition of GLT2 as well, so that we can work on avoiding cardiovascular events and or achieving benefit. Of course, pioglitazone can be considered, but we have to be careful with its side effects. Now, once indicators of high risk and even additional other issues related to heart failure, then SGLT2 is an important contributor. CKD by itself, especially if they are already managed with ACE and ARBs and or related drugs to help improve outcome with the SGLT2 and or need for initiation or no initiation of dialysis, and of course making sure that efficacy for reduction of EGFR is in a way prevented. So with that, again, the GLP-1RA can be considered with proven CKD benefits. If HbA1c is above goal for these patients, SGLT2 along with SGLP1RA will be considered. Now, primary outcome then is based on the once weekly subcutaneous semaglutide, and this have resulted in a 26% reduction of MACE, and this was not only non-inferior, but also superior to a standard of care. The number of patients needed to be treated over 2 years was only 45 to get benefit. Now, let's look at the expanded composite outcomes that I mentioned earlier in SUSTAIN and in the studies that looked at the outcome of semaglutide benefits. And clearly, you can tell that the most important related benefit is non-fatal stroke, also found with non-fatal MI, and to a lesser degree with cardiovascular death. Of course, expanded outcome included also the benefit with the hazard ratio of about 26% risk reduction. Now, after 2 years of managing this patient, now 2024, you will see HbA1c drop to 6.3, weight from 68 to 54, actually 86 to 54, total cholesterol from 6 to 2, triglyceride from 3.9 to 1.9, LDL 3.16 to 1.7. And of course, these two goals were achieved, the HbA1c and weight reduction. Again, the difference is addition of Ozempic along with the change in lipid treatment. Now, this is a little bit of a different type of patient. I wanted to show you now how important is the compliance. This patient, 65-year-old, referred to cardiology by diabetologist. He was seen first by me in June 2024. At that time, his weight was 130. He was already planned for reduction, but this is what he was at that time. And BMI was 41. And of course, his diagnosis was central obesity, metabolic syndrome. His chief problems were hypertension, hyperlipidemia, uncontrolled diabetes on insulin, HbA1c 8.3, knowing that even it was higher. Pulmonary embolism had happened in May 2023, for which he is receiving oral anticoagulants. Upon coming to me, patient was already on Victoza, and I took over, started Forxiga, which is dapagliflozin, and Ozempic, 0.25 milligram to be increased to 0.5. Of course, in addition to his usual insulin treatments, Olmetic, etc., for his blood pressure. Now, I've seen him 3 months later, and with that, he started to lose weight, and he was supposed to be on 0.5 milligram Ozempic subcutaneously. Unfortunately, patient just did not come back up until the time I saw him in hospital in April this year. Now, what happened over the few months that followed, initially he continued to lose weight up until he lost a total of 13 kgs. But based on my recommendations, and even the diabetologist who probably seen him more than I did, he did not listen. He stopped his Ozempic. He started Mounjaro, then stopped Mounjaro. He started other injectables, again stopped them. Anyway, over the last 4 or 5 months prior to his admission to the hospital, he was literally taking nothing. all the weight gain, the weight loss that he had were regained progressively. He was admitted with decompensated diastolic heart failure. And when I saw him, I discussed the whole story with him and reviewed all what had happened to him. Basically, I reiterated to him the need to return to the same treatments as previously recommended. Now, having lost 13 kilos, at that time, he was back to 129 kilos as if we started the year before. On July 7, he was discharged, and I followed him just last month, and I reiterated the emphasis to establish a new management plan. So, in summary, after initial loss of weight, up to 13 kgs, down to 117, having stopped the treatments, even when switched to Saxenda, he did not continue. Patient regained all the weight, hospitalized for diastolic heart failure, but after counseling and repeated agreements with him, he agreed to do so. And look at the way his pattern of lab results occurred. His NT-proBNP dramatically increased to 5,600 before admission, only to drop down after he started treatment quite rapidly, actually, from 5,000 to 2,000 to 60 and 189. Microalbumin was high, also dropped. Total cholesterol was quite high, and that included the earlier years. Anyway, it dropped only to rise again because he stopped also his anti-lipid. LDL cholesterol dropped dramatically to 1.5, only to rise again. And HbA1c related random blood sugar, again, it was 12.5 down to 8, then up to 7, and now back up to 9. Now, this is just an example how compliance to the combination therapies that we establish, along with lifestyle changes, that this patient unnecessarily denied himself of this benefit, and how the benefit occurred, how it was lost. For that, I think the combination therapy and along with lifestyle changes would have saved him all this trouble, but that was the case, and I thought it would be reasonable to share this case with you. Here, I would like to stop and ask you for your opinion and questions and answers. Thank you.
Thank you very much, Dr. Samir. It was a very thorough and impressive discussion, presentation. Now, we have some few questions, and I do encourage everyone who has a question to submit to the Q&A. Someone is asking, what is cardiovascular residual? Let me readdress that again, saying that even after optimal glycemic control, patients with type 2 diabetes remain at risk for cardiovascular disease, whether it's all major cardiovascular events, heart failure, stroke, peripheral artery disease, cardiovascular death. Patients with diabetes are at increased risk of cardiovascular disease and kidney disease as well. Now, reducing that can happen with different types of medications. And as addressed, some medications like DPP-4 inhibitors, insulin, sulfonylureas, they don't have any cardiovascular benefits. Specifically, GLP-1 receptor agonists, SGLT2 inhibitors can reduce the risk. Yes, the risk is not reduced to zero. Our diabetic patients are still at high risk. So that's what we mean by cardiovascular risk reduction. So Samih, you addressed a very, very important topic, which is patient compliance. In your practice, how compliant do you see our patients on long-term therapy? It's a weekly injection with some side effects. How many of your patients actually maintain the medication? As you mentioned, some of them will stop it. Some of my patients stop it as well. How do we address that? How do we help them? How's your experience with that?
Yeah, I have to admit that this is an important problem. And perhaps this is why I presented this patient titled as non-compliant. Uh, there is a fair percentage of patients who would probably, unfortunately, listen or hear the internet or the YouTube and does not necessarily comply. There is a big scare about the issue of thyroid disease, where it has actually no base at all, except for a very rare thyroid cancer, familial type, that is exceedingly rare. And people just mix things together. And for fear of that, they may stop the medicine. Others may stop it because of gastrointestinal GI effects that may, for some reason, patient considers it as important enough not to continue. But those who continue on receiving, first, the gastrointestinal effects become milder and more tolerable. And by the time they establish the treatment on a longer period and steady pace, they will notice less side effects, and they will observe the difference very early, which encourages them to continue. Unfortunately, some patients will miss that interval of improvement because of their intolerance. And I keep trying with my patients, those who are not necessarily compliant, to convince them to do so. So, for example, this patient of mine, he admitted that he messed up all his management for social reasons, as he admitted. But now, looking forward to see him in the near future, and the hope that he will give us better compliance.
I hope so. As you addressed, I mean, unfortunately, our social media is filled with lots of malinformation about treatments in general, whether it's our antihypertensives, antidiabetics, statins, anti-lipid treatments, and people unfortunately listen to that. The other problem is shopping around from one place to another and one hospital to another, listening to so many people, not going to the experts or to the people who actually manage these patients. So the compliance is an issue, and I hope with time we get our people more knowledgeable. There's another important question here, which is nice, about the role of these medications in reducing peripheral artery disease in amputation in diabetics. How can they help?
Well, in the STRIDE trial, there is improved functionality. Walking, 6-minute walking, and ability to be on a treadmill, flat or non-flat. So we certainly need more studies to help us decide whether peripheral vascular outcome benefits, including prevention of need for revascularization or amputation rates, that would probably complement the early evidence now that we have regarding the functionality benefit that has been shown. So I think it is most likely promising, but we need data.
There was a question about the use of PPIs to reduce the side effects. Definitely, you can use PPIs or any medications, any symptomatic, to reduce the symptoms of gastric symptoms of these medications. What about the use of these medications in non-diabetics? Whether it's cardiovascular patients, obese patients, what's the benefits of using them in non-diabetics?
Yeah, this is off-label. So particularly with the GLP-1 receptor agonist, Yes, I'm using in patients who are overweight and not diabetic and have other cardiovascular potential outcome benefits. Yes, I'm using. Uh, uh, Again, we need, like what happened with dapagliflozin, we need a study that does not include all diabetics. Some of them, none should be. And perhaps that will also support the concept that this is going to be of help to prevent outcome benefits, to improve outcome benefits.
Again, we have in the SELECT trial, those who had cardiovascular disease, there was a significant reduction in cardiovascular outcomes beyond obesity and beyond diabetes. So in cardiovascular disease patients, high-risk cardiovascular disease patients, SELECT trial, there was a reduction. Now, in general, the safety profile of the drugs is good, and obesity by itself increases the risk of other disease. So, as I said, if you use it for obesity management by reducing obesity, you reduce the risk of cardiovascular disease as well, or the complications as well. There is a question about the comparison of oral versus injectable semaglutide. What's the difference and what's the benefits and the outcomes and the side effects as a comparison?
Well, in principle, some patients would tell me, look, I will accept some nausea once weekly, but I may not accept it every day. Although I keep telling them that even if it is there occasionally, frequently, it will gradually disappear. One issue I usually tell my patient, and this is actually in the literature, is that if you select your diet or your meal after the oral semaglutide with much less or no carbs, the side effect is much less. So as if the pill is telling my patient, please do not eat carbs, because if you do, you will have side effects. And once the patient adopts this attitude, the benefit is even doubled. The benefit is even more. So in a way, I would say, yes, some patients would say, I don't want injections. I don't like frequent injections. And as I said, some patients will say, I don't want nausea every day. So I've been balancing things between the two options to get the benefit that the patient would desire.
Excellent, excellent. Now, so oral semaglutide does still not have the labeled indication for cardiovascular disease reduction, although the SOUL trial has been there. So for cardiovascular disease reduction, we still prefer the injectables, but again, we would not deny the patients the benefits if they feel that it's easier to take the oral for compliance or for side effects or for whatever.
As opposed to the injectable.
Exactly. For the sake of time, I might just say that this highlights the importance of the strong communication between the clinician and the patients, the patient-centered care. It does highlight the importance of patient compliance for better outcomes. It's not enough just to prescribe the medications. And it's very important to be updated for all of us as healthcare professionals with the proven medications for our patients, especially our high-risk diabetic patients who deserve the best benefit to reduce the cardiovascular outcomes. Dr. Samih, if you have any final words, anything to say before we close?
Basically, I would say, as you actually started with your presentation, that diabetes in Saudi Arabia, in the Gulf, and probably in the region, is a very critical contributor to our bad outcomes. Let's put it this way, whether it's cardiovascular, kidney, cardiovascular, vascular as coronaries, or heart failure, or related issues. For that, every effort and every aspect of care should be addressed by our professionals without allowing the media. And I hope the Ministry of Health, and you are one of the leaders, would address the importance of mind destroying that is happening through the media, so that we can improve our relationship with our patients and become more one-to-one relationship in their getting their target of the best benefit, in particular related to cardiovascular outcomes.
Thank you very much, Dr. Samir, for this informative lecture and meeting, and to thank the audience for being here. MashaAllah, we surpassed more than 1,000 attendees. And I also thank Novo Nordisk for sponsoring such an interesting, important meeting. Thank you very much, and a good night to all of you.
Thank you very much. It was a pleasure.
Thank you.